Thank you, sir. I would like to thank the organizers for giving me this opportunity. So, so this will be the outline. First, we will discuss the magnitude of the problem and then various preventive strategies with overview and some specific and some general preventive strategies. So, alcohol has become the most common etiology of cirrhosis in adults in India. This was meta-analysis of 2024. About 43% are due to alcohol. Fatty liver is also uh, becomes a large chunk. There is reduction in the viral hepatitis related cirrhosis over time. Fatty liver is the most important risk factor for both cirrhotic and non-cirrhotic HCC in India, and as we can see, 30 and 48% of cirrhotic and non-cirrhotic HCCs are now related to fatty liver disease. Now, India still ranks second in the global burden of hepatitis B and C, and for hepatitis B, it is behind China, and for hepatitis C, it is second behind Pakistan. And alcohol consumption is also rising. Alcohol consumption per liter is increasing. Current drinkers are also increasing from 210 to 2019, and alcohol amount that is being drunk per drinker is also high as compared to the world and also as compared to the CRO countries. And NFLD prevalence is also quite high. This was a meta-analysis which suggested that overall about 40% adults and 35% children have NAFLD, and in high risk groups it almost reaches 60%, and in obese children up to 63.4%. So what are the levels of prevention? So at the societal level, it is a primordial prevention, and other preventive strategies like primary, secondary and tertiary prevention are at the individual level. And overall preventive measures can be non-therapeutic, that is lifestyle measures that are very important, and therapeutic measures can also be taken. This is the overview. So primordial or primary prevention, basically immunization, safe blood, decrease alcohol use, decrease fatty liver disease. Secondary prevention to diagnose and treat viral hepatitis early, treat other etiologies of liver disease, lifestyle modification, and tertiary prevention like prevention of infection, lifestyle, diet, frailty, and actually it includes whole of the hepatology. So we'll see some of the strategies. So as far as viral hepatitis is concerned, the WHO has the global agenda to decrease new infections by 2030 by 90% as compared to the 2015 baseline, and 65% reduction in deaths due to viral hepatitis. And 5 main interventions have been suggested by WHO to eliminate viral hepatitis, with some targets have been set up which are quite ambitious, but we need to focus on them. Mainly hepatitis B vaccination, mother to child, blood injection safety, drug use, and HBV and HCV treatment strategies. So as far as coverage of hepatitis B birth dose is concerned, this was the WHO data. In 2022, India falls in the 50 to 80% range. So we have to work in that area also. And coverage of hepatitis B C testing and treatment is one of the lowest in the Southeast Asian region. Hepatitis B patients who are diagnosed with hepatitis B and patients who have diagnosed and receiving treatment for hepatitis B and C are quite low. Now, most of the current guidelines that were used quite for some time, they do not actually they do not predict development of HCC. For example, this was a study which showed that many patients who were still on treatment developed HCC, and people who developed HCC, some of them did not meet the treatment criteria according to ASLD, EASL or APASL, and the percentage of people who developed HCC and did not meet treatment criteria actually dependent on how conservative the treatment guideline is, APASL being the most conservative, that is they were very strict in starting treatment. So There have been potential strategies for expanded HBV treatment. We will discuss this. First strategy is test and treat all. Do not even test HBV DNA. Uzbekistan is going in this direction. Second strategy is treat all DNA positive. And China has already implemented this, and a Basel Elimination Task Force recommends this. Then there is another strategy, opt-out strategy, that is exclude low-risk patients, and WHO guidelines belong to this category. INASL guidelines has also can be included in this category. Now, there have been multiple studies which show that the quickest strategy to achieve the 65% mortality target reduction is 80% coverage of 18 to 80 years. Then only we can achieve this target. This has been a decision tree Markov modeling from the Chinese population. And this strategy is actually cost effective also. So after these are the Chinese guidelines and the Basel Elimination Task Force guidelines, and about 92% of the all patients with HBV in China are now considered eligible for treatment. And recently WHO guidelines have come, and which also in effect increases the number of patients who would now be eligible for treatment. And implementation of these guidelines will result in a number of people living with hepatitis B who can access treatment will increase to up to 50%, but is still 50% will not be eligible for a treatment according to these guidelines. Now WHO has laid down detailed guidelines on global health sector strategies or on viral hepatitis for 2022 to 2023 and 2030, and focusing on various strategies that need to be followed. Now this guideline says that new action should be taken, because if we continue to do what we are doing, then these are the projections. We will nowhere be near to the achieving our targets in both hepatitis B and hepatitis C. So this suggests that key shifts that are required to the paths of elimination: greater public awareness, increasing financial resources, universal access to hepatitis B vaccination, continuous investment in primary prevention, increase access of hepatitis B and virus testing, simplified and decentralization of all the services is required, strengthening community and civil society, stigma and discrimination. These are some of the issues that need to be tackled. As far as alcohol is concerned, WHO has published Global Action Plan again for 2022 to 2030, and this is given 6 key areas focusing on strategies, advocacy, partnerships, capacity building, knowledge production, and resource mobilization. And again, various targets have been set by WHO. By 2030, 75% of countries need to introduce policies, at least 25% reduction as compared to the 2010 in alcohol per capita consumption, and 80% of the world population are protected from harmful use of alcohol by various strategies. Now, this was an interesting study from from 20 countries in Latin America, which showed that alcohol related mortality depends on how many public related health policies are being followed in that country. So number of public health policies, as it increases, the alcohol related deaths decreases. And the 2 most important policies were that there should be a national plan. This is the most important strategy, which has high predictive value, and restriction to alcohol access. So these were the 2 policies with maximum impact on alcohol related mortality in any country. Now India is quite lacking in alcohol policy front, and this was in national newspapers recently. So it said that on policy measures, report found no Indian data relating to what kind of health warnings are there, underage drinking, drunk driving, cancer, and no data to display consumer information on all the containers. We know that in patients with liver disease, abstinence decreases the risk of decompensation and mortality in alcoholic cirrhosis and also alcoholic hepatitis. And there is no level of alcohol consumption that is safe in patients with any kind of liver disease, no alcohol, and even in general population also, no alcohol level is considered safe. So, but saying that you don't drink alcohol doesn't mean anything. You have to, we need an integrated AUD clinics for with the collaboration between psychiatrists, counselors and hepatologists. There have been various studies which show that integrated care leads to better abstinence. And this is the AUD clinic protocol for ILBS, which is quite multidisciplinary, and it involves various various questionnaires and various interventions, including medication, counseling, psychiatrist use, and counselor use. So we need to be really multidisciplinary in patients with alcohol use disorders. And as far as NAFLD is concerned, voluntary global targets for 2025 have been set by WHO. There are 9 voluntary targets, 25 indicators, including various areas, including alcohol, physical inactivity, sodium, tobacco, and so on and so forth. NAFLD has recently been included in non-communicable diseases prevention program in February 2021, but very dismal data, about half of the Indians do not have sufficient physical activities. This was the 2022 data. About 50% of the patient, 50% of the population in India do not do adequate physical activity, and India is quite off track to meet the global target if trends were continue like this. And WHO has the target of 15% reduction in insufficient physical activity between 210 and 30. In 2000, insufficient physical activity was 22.3%. In 2020, 49.4%, and 2030 projected is reaching up to 60%. So awareness and partnerships are very important. Stakeholders, public, patient, schools, NGO, government should be involved. Hepatitis Day, we have Liver Day, we have Fatty Liver Day. Similarly, all institutions should play their role in awareness and partnership. For example, ILBS is doing its own way of various programs, Smiles, iMeld, Empathy, etc. Now, this was a study from ILBS which were done in 3 schools in Delhi. We showed that specific health education initiatives can lead to raising public awareness and comprehension, and pre-intervention and post-intervention scores in all the schools were much better as compared to the pre-intervention. So, specific health education initiatives are very important. Now, exercise and dietary interventions in cirrhotic patients are very important. There are various exercise interventions, aerobic training, resistance training, strength training, and it can improve physical fitness, it can reverse or halt sarcopenia, it can reverse frailty also. Studies are actually quite limited by small sample size, and this was our experience. We have a liver habitation center at ILBS, and these are the type of exercises and frequency, intensity, and how much time. It is done under the supervision of physiotherapist. We also take care of nutritional requirements of these patients, and exercise program needs to be tailored according to the physical capacity of the patient. And this was the data which was presented in EASL 2020. 4 weeks of aerobic and resistance training improves frailty in patients with liver cirrhosis, mostly child A and B patients. So after 4 weeks intervention, actually the protein intake increase, liver frailty index increase, 6-minute walk test increase, gait speed also increase. So we have to put patients, and we have to motivate them to have adequate diet and nutrition and exercise. So to summarize, ladies and gentlemen, hepatitis B, C, alcohol, fatty liver are important etiologies of chronic liver disease, and most of the chronic liver diseases are actually preventable and modifiable. Interventions of primordial or primary prevention include immunization for HBV, early detection of HBV and HCV, reduce alcohol intake, reduce fatty liver and obesity. Most important secondary prevention measures are early treatment and early diagnosis of viral hepatitis B and C. And we as a country and society need to work towards achieving targets that have been set by WHO for viral hepatitis, for fatty liver and for alcohol. Specific health education initiatives can raise public awareness, and in patients with cirrhosis, appropriate use of lifestyle approaches and various therapeutic approaches are important to reduce mortality. Thank you very much.